Good evening, and thank you all for joining us for another installment of our Ask the Doctor series. I am Titania Bailey, president of Arc of Knowledge, Inc., a nonprofit organization that provides resources towards building and strengthening relationships between our youth and seniors. And as part of our generational health and well-being initiative, we have the pleasure of partnering with MedStar Health and their team of specialists to provide education and resources that promote better health practices. Before I introduce our speaker, just a few quick reminders. Remember to keep your devices muted throughout the presentation, and all questions can be entered into the chat and will be addressed at the end of the session during the Q&A portion. Our speaker for today is Dr. Patricia Wainer. She is a board certified surgeon with fellowship training in breast surgical oncology and an attending physician in the MedStar Breast Health Program at MedStar Washington Hospital Center. She earned her medical degree at the University of Maryland School of Medicine and completed her general surgery training at MedStar Washington Hospital Center, followed by a surgical breast oncology fellowship at the University of Southern California. Under the guidance of Dr. Melvin Silverstein, Dr. Wainer won the Scientific Impact Award at the 2013 American Society of Breast Surgeons Annual Conference. Her special interests include ductal carcinoma in situ, intraoperative radiation, oncoplasty, and benign breast disease. Please welcome Patricia Wainer.
Great, thanks for having me. I'm sorry I'm a little dark. We just moved offices this week and I have no idea what the lighting looks like in my office. So it is definitely a wee bit dark. But I'm happy to discuss kind of breast cancer, some of the things that everybody should know about breast cancer, as far as screening, what to know if you get diagnosed with breast cancer, and kind of some of the options that we have for you. Just a heads up, as I do go through a PowerPoint, I do have some pictures, and so be aware some of them are during surgery. So if anybody's squeamish, you may want to look away from your computer briefly. But there are definitely a couple surgical pictures because I think the best thing to do is really share some photos. Unfortunately, I had a few more to share than what I have today, and I had redid my PowerPoint yesterday, and apparently it only got saved at my other office. So we have a little bit of a foreshortened one. So I am a breast surgeon. I specialize in breast cancer care, as well as high risk benign lesions and kind of preventative things to do for breast cancer. I work out of MedStar Southern Maryland Hospital and MedStar Washington Hospital Center. So I really do kind of take care of that whole region of Southwest DC into Maryland is where most of my patients come out of. So I'm going to share my screen. Please, if you guys have questions, let me know. I know everybody always has a lot of questions when it comes to kind of breast care and what they should know. And let me see. Are you seeing screen one? The PowerPoint? No, let's try that. All right, that looks like that should be working. And okay, hold on. I cannot put it in speaker form because it takes away my ability to see any of you. Okay, so let me see. All right. So we're here really to talk about breast cancer and breast cancer care. So some of the things that we'll go over is kind of how common is it? What should I do if I'm diagnosed with it? Is there anything I can do to prevent it? And then if I really do end up with a diagnosis, you know, what are my options surgically? So what is it that I can discuss with my surgeon and what should I expect to look like afterwards? So how common is breast cancer? Well, breast cancer is the most common cancer in the US for women. It's currently the second leading cause of cancer-related deaths in the US. Good news is the cancer rates have steadily been declining since the 1980s. One thing, however, we have seen since COVID is we've seen a little bit of stage migration, meaning when we would see a lot of patients who present with really early stage 0 or early stage 1 breast cancers, throughout COVID, we've actually seen a little bit of a stage migration, so a little bit more of later stage 1, stage 2, or even stage 3 cancers, just because patients stopped getting their screening mammography during COVID because we didn't really know what was safe to do or not do. So we have seen a little bit of an increase in some of these cancer-related deaths around COVID, but I expect those numbers to kind of start to settle out as we get further and further away from COVID. So what is breast cancer? Well, it's the abnormal growth of cells that invade normal tissues within your body, and in this case, invade breast cells. So it can start anywhere within the breast. There's not a particular breast that it starts in. It can be in any quadrant. It can be close to the nipple. It can be far away from the nipple. So there's not really any rhyme or reason as to where it occurs in the breast. Your breasts are made of lots and lots of milk ducts. And they all come and join up at the nipple. And behind the milk ducts are these things called kind of lobules. And these are the milk producing portions of the breast. If it's in the milk duct, so if it's here, we call it invasive ductal carcinoma. If it starts up here in the lobules, it's called invasive lobular carcinoma. The two types, invasive ductal versus invasive lobular, are treated fairly similarly. It just has to do with where in the breast and what type of cells in the breast it started from. So generally, how I like to explain this is if you think of your breast and you think of lots of milk ducts that come through the breast and join up at the nipple, think of it as kind of the milk pipe or the milk tube of the breast. There are little cells that live on the outside. They all look the same. They all do the same. They're very normal. But once in a while, you may see one or two of these cells that look a little bigger and a little bit more abnormal. When we just see kind of one or two of these cells that look abnormal, this is when we start to call it atypia. So atypia just means something that's not normal. The other term that we'll use formally for this is atypical ductal hyperplasia, or ADH. And what this is it's considered a high-risk lesion. So while it's not cancer in and of itself, it is a marker for the development of cancer. And so for patients who have developed ADH, we know that they have a higher risk compared to the average population of going on to develop actual cancer, and not even necessarily at that site. It could be anywhere in either breast later in life. So for patients that we find who have ADH, we frequently will take out that area, but we'll also follow them closely long term just to make certain they don't develop cancer. If you continue on the spectrum of changes, though, that we see in the milk duct, other times almost all of the cells inside of that milk duct get really big. And so when that happens and it starts expanding kind of the size of that milk duct, this is what we call DCIS, or ductal carcinoma in situ. So in situ just means inside the duct. So cancer inside the duct. And so DCIS is our stage 0 type breast cancer, and stage 0 just means it's cancer cells inside a duct. Then other times those cells start to grow outside of the duct. So when they start growing outside of the duct, they can form kind of a tight ball of tissue that you could feel. But this is when we start calling it invasive cancer. So invasive ductal carcinoma. And this type of cancer is what's considered our stage 1 through stage 4 breast cancer. So 1 means it's very local. 2 means it's a little bit bigger. It's potentially even starting to move into the lymph nodes. 3 means it's very big and maybe there's a lot of lymph nodes. And 4 means we've already seen evidence of it living someplace else in the body. Stage 0, stage 1, and even early stage 2 are very, very treatable. And so the earliest stage to catch it is a stage 0, but we frequently also catch it at one. So what causes breast cancer? And this is what almost every woman who comes into my office asks me, kind of, what did I do? Is there something I could have changed? And the answer generally is not really. I mean, we don't know what causes most of these. We do know there is a genetic link. So we know that families who have significant history of cancer, particularly breast and ovarian cancer, have a higher risk themselves of developing cancer. We know that some of those cancers are linked to genetic mutations, but a good number of them are not. So Angelina Jolie, this is probably about 12 years ago now, was all over the news because Angelina Jolie actually does have a genetic mutation. So she has an inherited mutation. So she has the BRCA gene. And so patients with a BRCA mutation have as high as 85% over their lifetime of developing breast cancer and can be as high as almost 60% of developing ovarian cancer. So patients who have a known genetic mutation, we frequently recommend prophylactic surgery, so prophylactic removal of the breast plus or minus reconstruction, and prophylactic removal of the ovaries once they're finished childbearing age. So Angelina Jolie was all over the news many years ago because of the fact that she had bilateral mastectomies. And she didn't do it because she had a cancer diagnosis. She did it because she had tested positive for a genetic mutation that made her at such a high risk of developing cancer. Most patients who we see test negative for a genetic mutation. So even patients with significant family history and even patients who develop breast cancer at a very young age, so younger than 50, even younger than 40, most of them test negative for genetic mutation. And so genetic mutations really only account for about 10% of all breast cancers. So that means 90% of them are not accounted for known genetic mutations. So we do know there are some risk factors. Some of these can be changed. Some of these can't be changed. And so the big question is kind of, what are some of those, and what is it that you can or cannot do to help prevent breast cancer? It's not quite as easy as, say, like melanoma, where we know that patients who are in the sun a lot and have a lot of burns have an increased risk of melanoma. It's not quite as simple when it comes to breast cancer risk factors. Gender is number one thing. Being a female puts you at a much higher risk than developing breast cancer than our male counterparts. Male breast cancer does happen. I normally see about 1 or 2 male patients a year that have developed breast cancer, but women are 100 times more likely than a man to develop breast cancer. Age is really one of the number one risk factors. Although we are seeing breast cancer develop at a younger and younger age, really the older you are, the more likelihood that something is going to develop. And for many women, that ends up being breast cancer. Now, the one good thing is for most patients, if they're elderly when they're developing breast cancer, most of them are developing a hormone-positive breast cancer, which is considered kind of a little bit less aggressive and a little bit more easy to treat. Age is definitely a huge risk factor. Genetics, as I had mentioned, only up to about 10% of breast cancers are truly genetically linked. Genetic testing used to be incredibly expensive, and it used to cost like $10,000 to get a genetic test. That test, even if you do not meet criteria for testing, is now much, much, much more reasonable. And the company that we use charges about $250 for the test. So even if insurance doesn't cover it, it is definitely much more accessible than it used to be. But there's more than 2 main genes that we look at. We do look at the BRCA1 and the BRCA2 gene, but there are about 80 different genes on some of these panels that we're checking. Family history, so having a close blood relative puts you at a higher risk of developing breast cancer, even though we know that we don't know what the gene is that's linked. I'm sure there's something that we just don't know about yet. and even having a personal history of breast cancer. So people erroneously think that if you've had bilateral mastectomies, then you're kind of done with everything and don't need to worry about it again. And that unfortunately is not true, because having had breast cancer previously always means that you could have a recurrence, even in mastectomy bed. Diagnosis of the precancer cells, so atypical ductal hyperplasia, as I had mentioned before, anybody who has that diagnosis is at a higher risk of developing breast cancer over their lifetime. People who've had previous chest radiation when they were younger, so if they ever had mantle radiation when they were much younger, also that radiation paradoxically increases their risk for developing breast cancer later in life. Postmenopausal hormone therapy. So, for a long time, we used to replace everybody's hormones. So everybody took exogenous hormones, and we thought we were being really great and helping patients and, help alleviating some of their menopausal side effects. Unfortunately, we discovered that all of that exogenous hormones wasn't doing what we thought it was. And the biggest thing that we thought it was doing was actually helping from a cardiac standpoint, so helping lower cardiac risk. We found that giving all of this exogenous hormones actually increased cardiac risk. So it actually increased cardiac arrest in females over time, and it also increased breast cancer. So we recommend basically not to take long-term exogenous hormones, and if you're going to take it, there should be a reason and kind of a time period for most of us. There is some link to hormonal contraceptives, especially later in life. However, once you stop them, that risk returns to normal. So it's one of those things, if you're really young and you're taking hormonal supplements, that's fine as a hormonal contraceptive. But it's once you get a little bit older and start going past 30, we recommend, there be a discussion of your personal kind of risk based on family history. Race can be a factor. So white women actually get breast cancer at a much higher rate than Black women do. Unfortunately, most African American women are more likely to get a much more aggressive form that we call triple negative. So when we get breast cancer, there are three main subtypes of breast cancer that we look at, or three main receptors. So there's something called an estrogen receptor, something called a progesterone receptor, and then something called a HER2/neu receptor. So these receptors, when we look at breast cancer, either stain positive or negative for each of the three. And so we then subtype or categorize the type of breast cancer you have based on what those receptors are staining for and whether they're positive or negative. Positive breast cancers are estrogen positive, progesterone positive, and those are called hormone positive breast cancers. If you have an estrogen positive, progesterone positive, and HER2/neu positive breast cancer, that's a triple positive breast cancer. If you have a estrogen negative, progesterone negative, and HER2/neu negative breast cancer, then that's called a triple negative breast cancer. And then if you have estrogen, progesterone negative, and HER2/neu positive, then that's a HER2 enriched breast cancer. What that has to do is it kind of describes how each of these cancers act a little bit different, but also it's really important because it helps us know what medications that we need to give to treat these sorts of cancers. So a triple negative cancer, meaning estrogen negative, progesterone negative, and HER2/neu negative, we still haven't figured out why that tends to be the one that shows up at a higher rate in the African American population as compared to the Caucasian population. There's a lot of research that's been going on trying to figure that out. We don't really know yet why it seems to have a predilection for one race versus the other. But triple negative cancers, because we know that it tends to be a bit faster growing and a bit more aggressive, is then treated more aggressively. So triple negative cancers are always recommended to undergo chemotherapy. For patients who have hormone positive cancer, that's HER2/neu positive, for a lot of them, we don't give chemotherapy because we know there's no benefit. Now, there are some tests that we do that actually test tumor that you're growing that can help us delineate kind of who's really going to benefit from chemotherapy versus not. But when it comes to triple negative cancers or HER2 positive cancer, we are pretty much always going to recommend systemic treatment. And systemic treatment just means chemotherapy, so full body treatment. Another thing that can be a risk factor is really dense breasts. So I have lots and lots of women who come in here all the time asking me kind of, what does breast density mean? Like, why is it important? Why is it written on the bottom of their mammogram report? And what do they need to know? So I explain breast density very much as a black versus white image. So a really, really fatty breast is more black. A really, really dense breast is more white. So think of it kind of as a snowstorm. So if you walk out into the night and it's not snowing and it's nice and clear and it's a black night and you can see the stars really easily. And then as the snow starts to kind of trickle down, you're having a harder and harder time seeing kind of the stars in the sky until eventually it's like a blizzard and then you can't see anything. So if you think of a really fatty breast, which I have up, you can see, you see the skin really easily. This is the inside of the breast. And so when cancers show up, most of the time they show up as a little white kind of ball of tissue. And so if one popped up right here, it'd be really easy to see. So this is called basically a fatty breast. Then you get to something called scattered fibroglandular elements, and that's what we're at here. And you see just a little bit more weight. So it's starting to snow just a little bit, but it's still pretty easy to read. Then you get to what's heterogeneously dense, and you can see more and more kind of white thickened tissue in here. So if you had a really tiny cancer, it's getting a little bit harder to read. And then the last one is a really extremely dense breast, and you can just see that if you had a really small little white lesion here, it'd be much, much more difficult to pick up on that image as compared to this image. And so that's why at the bottom of mammograms now, they mention something about density. Most women now are getting a 3D mammogram. A 3D mammogram looks like this, but then in addition to this image, we also get images that we can scroll through. So it's kind of like a flip book of the breast. And so it does make it much easier and much clearer to see. It's still never going to be perfect like this is, but you will definitely see a difference. So what else are a few risk factors? So not having kids or not having them until later in life, not breastfeeding. And basically all of this has to do with just having more menstrual cycles. So more changes in your hormonal levels from a month-to-month period. We know that physical activity will lower your risk for a lot of things. This also includes breast cancer. So trying to be healthy, trying to maintain a good balance is always important. Trying not to be overweight because fat actually produces estrogen. So it produces extra hormones. So even if you're older and you're postmenopausal and your ovaries aren't working, if you're obese, you do have a lot of extra estrogen that your non-obese counterparts do not have. There's also a link to alcohol use, particularly in the postmenopausal female. So if you drink greater than 2 to 3 drinks a week, then there actually is an increased risk of the development of breast cancer in those postmenopausal females. So, what can you do? Because that's what everybody wants. Be active, be healthy, limit your alcohol. If you're young and still haven't had kids, breastfeed, as that helps. Don't take unnecessary hormones if you don't need it. So how do you prevent breast cancer? So for patients who have a really strong family history, we do genetic testing. And if they're genetically positive, then we may offer them prophylactic mastectomies. If patients have atypical ductal hyperplasia, so they have that high risk kind of marker that they've already developed, sometimes we recommend chemoprophylaxis. So it's basically a hormone blocker that we recommend they take that can help reduce their risk. But then what if you really are diagnosed with breast cancer, right? So one of the biggest things is you need to find a team you trust. So talk to your friends, talk to, people in your close circle, talk to your church members. There's always somebody who's gone through this. And really find yourself a breast team that is as top notch as you can find around you. Find somebody who's part of a multidisciplinary group, because all breast cancers are treated as a large group. When a patient sees me, we talk about every single new cancer diagnosis as a large group. And that large group includes an imager where we review imaging, we review the pathology slides from what was biopsied. We talk as a medical oncologist, radiation oncologist. We talk, with our rehabilitation folks, we talk plastic surgery. So it's really important that wherever you are getting treated at, that you're really getting treated as a multidisciplinary group. So what are the options once you're diagnosed? So surgery is a key piece. Radiation therapy may be part of it. Chemotherapy may be part of it. And endocrine therapy may be part of it. Some patients get all of them. Some patients get not just like one or two of them. And every once in a while, for patients that really aren't in good shape, get none of them. So the local treatments, and local meaning just to the breast, include either surgery or surgery plus radiation. Treatments that are to the entire body are considered systemic. So that means whole body treatments. So that's kind of chemotherapy, or it can be a pill that's called endocrine therapy. And which ones we choose, some of it depends on you as the patient. Some of it depends on how large your breast is. Some of it depends on, how large your tumor is. And so there's no perfect answer, because not everybody fits into the same box. And so it does require a lot of discussion with your team as to what's going to make the most sense. So a lumpectomy, which also can be termed a partial mastectomy, it can be termed a segmentectomy or a quadrantectomy. There's lots of terms, and they all just mean part of the breast. So take out the tumor, get some healthy tissue around it. A mastectomy is the entire breast. So a mastectomy means we're taking the entire breast, and that can be done as taking it and leaving it flat. That can be done where we take the breast, but we leave all the skin and the nipple, and we reconstruct it. But that then has to deal with what your goals are as a patient. Anytime we do a lumpectomy, so anytime we save part of the breast, we generally will always recommend radiation, because we know that radiation coupled with a partial mastectomy gives the exact same survival benefit as if you've removed the entire breast. So many patients erroneously think that if they get a mastectomy, that, it's a better option for them and it's going to save their life. And that's not necessarily true. The other thing that lots of women think is if they get a mastectomy, then it means they're done and they don't need any other treatment and they don't need to worry about things, which also is not true. So even after a mastectomy, there is always a risk of recurrence. So things can always grow back in the mastectomy bed. And taking the other breast doesn't necessarily help. So doing a bilateral, so both sides, also doesn't confer necessarily a better outcome, because we know if you leave the other breast intact, the risk of developing breast cancer on that is only about 4% at 10 years. So the overwhelming majority of patients are not going to have a problem. So now I have pictures. So some of these are very graphic, so just be aware. But so historically, old mastectomies removed everything. See ribs and skin, basically, because they took all muscles, all lymph nodes, they took everything, and it was incredibly disforming. They then kind of got a little bit better. And then eventually, back in the 80s, they started pioneering kind of lumpectomies. So what if we just started taking part of the breast? Unfortunately, they did it in ways that weren't necessarily the best cosmetic ways. And so while patients still had part of their breast, it didn't necessarily look that great. And so now in today's world, we try to marry the thought of how do we get the tumor out, because cancer first is always our goal, but how do we employ maybe some plastic surgery techniques to really try to make it look better so patients feel better about themselves? And so this is one we do a lot. This is called kind of a radial ellipse, and you can see here it's very well healed. You can see she has great contour, and you wouldn't really notice this a whole lot unless I was pointing it out to you. This patient had a 2 centimeter here that was sitting kind of right here. This breast was always a little bit smaller than this breast, but this is about 10 days post-op, and her incision is kind of right here above the nipple. But this was over 10 years ago for this patient. I do not have a follow-up picture, but you can see even 10 days post-op, she looks great. This is kind of some of the more creative ways that we remove tumors. So this is basically called a reduction lumpectomy. So for patients who have larger, more heavier, more ptotic breasts, a lot of times with the aid of our plastic surgeon, what we do is we take out the cancer, but then we also lift the breast and make it smaller and kind of set nipples back where they should be, because as we get older, most patients' nipples no longer sit where they used to sit. So here, this patient, we don't use wires anymore, by the way. We used to localize everything with wires. We now have an implantable thing that we don't have to do this. But this marks where her tumor was. And so then what we do is we kind of open up this area, we lift the skin back, and we remove this part of the breast up here where the tumor is. Then what we can do after that is kind of reshape the breast, repackage the skin, and here she is. And I think this was also about 10 days post-op, because I can still see that these are very fresh wounds. But her incisions now are a standard kind of reduction incision. And most of the time, I don't make this counter incision for the sentinel node anymore, because I just get it while I'm removing this area of tumor. But it's a really good opportunity to get out areas of cancer and still leave patients looking good. This is another one that we do from time to time, where what we do is we open up around the nipple areolar complex. You create kind of a flap. I remove part of the breast, we close it back up, and then by kind of tightening that skin, it helps tighten that breast up, and it just allows us to remove some of it, but still leave a really good shape or contour. This is another one. Sorry, on my other PowerPoint that I happened to lose today, I would have shown you the intra-op photos. But this patient has a big cancer that was right here. And so what we end up doing is I kind of take just the skin here to close this down better. But then we make this incision, we take it out, and then the final incision is, let's see if I can draw it, it's just basically a flat line like that. But it keeps contour for this patient. Her breast looks very normal afterwards. It still ends up being a little bit smaller compared to the other breast, but it's a really good option of ways to get cancers out and still make women look good. This is another reduction, so you can see large breasts. Her nipples don't sit where they should. We've reduced them. We've taken out her cancer, which was way up here. And this is her post-op, and then this is her 3 weeks after surgery. We can also get really creative now with mastectomies. So this patient, actually, we removed both of her breasts. So we did a mastectomy, and what we're now doing is called a nipple-sparing mastectomy. So she was getting reconstructed with implants. So this was her before, this was her in surgery, and this is her at the end of surgery. She no longer has breasts. They've both been removed. They've been replaced with implants. But you can see, I mean, she looks great. And so even though she had cancer and even though she had to go through this, at least she's getting a decent response or decent result. This patient was prophylactic. She did not have cancer, but she wanted to go bigger. So skin and nipple sparing mastectomies for this patient. She's obviously a really good candidate because she's super small, but still we do incisions kind of underneath the breast, and she ended up with larger implants because that's what she wanted. This is another patient. This is a skin and nipple sparing mastectomy. This patient is 5 years after surgery. She has implant-based reconstruction, but these are not real breasts. They are implants that are underneath the skin. This is somebody who underwent reconstruction, but they had autologous reconstruction. So these are not implants. This was tissue that was living on her belly, and we took the fat and the skin that was living on her belly and recreated breasts that way. And we can take tissue from the belly, we can take it from the back. Sometimes we can take it from the thigh. Sometimes we can do something that's called fat grafting, where even after you've had surgery, maybe you have some area of dimpling or divoting secondary to surgery and radiation, and that can be fixed also, sometimes with just some fat grafting. So things to remember are we have lots of options. Picking a really good team is important when you're getting treated for any type of cancer, but definitely for breast cancer. We have lots of surgical options now, so ways to make things look good. So there's lots of different things that are going on that are out there, and so I just want to make certain that everybody knows that they do have options. I will, I guess, open it up for questions at this point in time. So what are we? Am I just going to the chat box? Is that where I'm going?
Yeah, I'm having some technical difficulties on my end. So yes, if you can go to the chat box and pull a few of those questions. I also have some that were sent directly to me, and I'll go over those.
The only one I see in the chat box right now that just says my arm won't stop hurting. Well, that's because anytime you get a sentinel lymph node, there are lots of little sensory nerves that live underneath the armpit. And so those nerves frequently get stretched or they get cut when you're removing lymph nodes. Those nerves will regenerate, and when they regenerate, they cause a lot of pain. So think like that sharp electric pain that you feel. That can happen when nerves are regenerating because they're basically sending signals to try to find the other end. Or if they were stretched, they're just trying to basically get stronger again. It takes a while for that to go away. That is not going to happen right away. Stretching, direct massage, pressure to the area, all of that will help make it feel better, but also time. Like it just takes time. Let's see. I had a bilateral mastectomy in July of 2019. I had genetic testing, which was negative. Do I need to be tested again? No. So if you were tested in 2019, you don't need to be tested at this point in time. Now, maybe in another 10 years, you could consider being tested again. Or if you had been tested back in 2008, it may be good to update your testing. But at this point in time, from 2019 to now, I would not retest.
Someone has their hand raised. If you would like to come off mute, you can come off mute and ask your question.
Hello, my name is Natalie Graham, and thank you for this evening. It was very informative. My mother passed of breast cancer. She had had it over her first breast removal, and then when she had it was like 15-year difference when it came back, and then she had a double mastectomy, and then over the years, then it went to her lungs, and she eventually passed. But my mother did have the genetic testing, and she told me that the genetic testing didn't show anything, and then that she had the gene, and then I had so now, knowing that this makes me high risk, I have been seeing like I have a breast doctor for the last 6 years. And I go to her just as regular as I go to my internist. And I took the genetic testing, and same thing, it didn't show anything. But I was told that the genetic testing now tests for way more, I guess, I don't know, way
Genes.
more genes.
Yeah. Yeah.
And so my question is almost similar to, do I need to take it again?
How long ago were you tested?
I think it was 2017 or 2018.
Yeah, I wouldn't. 2017 and 2018 are okay. I wouldn't repeat
Okay.
yet.
Mm-hmm.
At some point in your life, you're going to probably want to update it. But right now at 2017, 2018, you're okay. They were testing at that point for more than just BRCA1 or BRCA2.
Okay.
And if you have a copy of your genetic testing, it'll actually tell you how many genes they tested for.
Okay. I do have a copy, and my breast doctor looked at it, and so okay. So I'm just in like just learning everything I need to know, and just trying to do everything to prevent it. Like you said, I exercise every day. No alcohol, only occasionally here and there. Okay. And I breastfed my last 2 children. So I'm just, and every time I get to, learn more and more, that's why I jumped on this, just to keep learning more and more. So thank you for this evening and for
Very welcome. Are there any other questions that I would be more than happy to answer?
Trying to see if there are any others in the chat.
While you look there, I did take a couple of them down, but I think they were pretty much duplicates. But I did have a question.
Sure.
How maybe I missed this part. I did step away. How young would you recommend getting, I guess, tested?
Screened?
Yeah.
So screening, generally, we recommend to start at age 40 if you do not have significant family history. If you have significant family history, we recommend 10 years younger than the youngest kind of first or second degree relative. So say your mom developed breast cancer at 43, then we'd say you should start your screening at 33.
Okay.
So I have a
question. Okay. Sorry.
No, I'm sorry. So I was saying that my mom had breast cancer. I don't have it, but what about my daughters? So now, do I count that same age for them, that they should be, do I count that same timing for them because it was their grandmother?
How old was your mom?
When she first?
When she was diagnosed with breast cancer.
Oh, she was in her late 40s. I want to say 48.
Yeah, so then that means for your daughters, by the time they hit 38, they can have that discussion.
Okay.
Whether or not they want to start their mammographic screens at that point.
Okay. Thank you.
Sure.
Okay, so the questions that I received, one of them is, should patients consider clinical trials?
So clinical trials are always very important. And so, yes, I would recommend that patients consider clinical trials. Clinical trials are what have gotten us to kind of what we consider standard of care today. And so clinical trials are what help the fact that we no longer just treat every single breast cancer with the same type of chemotherapy medications or endocrine therapy medications. And so the reason why some of these cancers, we've learned that there's no benefit from chemo, or we've learned that there's actually no benefit from really aggressive surgeries. So some patients we can kind of dial back on surgery, particularly in the axilla, are all because of clinical trials. And so participating in them is incredibly important for us to keep learning about what is best for each and every patient, and really propelling us forward to figure out what's the best way to treat breast cancer patients. And so I think that if you have an opportunity to at least hear about them, you know, some of them may not interest you, but at least if you have an opportunity to hear about them, and maybe one of them's really, you know, targeted to your type of cancer, then I would say at least have an open mind to hear about it and decide whether or not you want to participate. Because at the end of the day, participation is up to you. But it's the only way that we've kind of moved forward with medicine is through clinical trials.
And are clinical trials given as an option during the discussions? I know that I think people have to bring it up on their own. Is it a part of the basic discussion once someone has been diagnosed?
It depends on where you're at. So it depends on what facility that you're being treated at, because it depends on what they have available. So the larger facilities are going to have more clinical trials that are available for more patients, just because they have money for research, they have an entire research team. So I work out of two hospitals. I work out of Washington Hospital Center, and I work out of Southern Maryland. Now, at Washington Hospital Center, we have a ton of clinical trials. And actually, when we present each patient at our multidisciplinary conference, one of the questions we always ask to the larger group is there a clinical trial available for this patient? And so it is then mentioned to the patient. At Southern Maryland Hospital, I don't currently have that, but we actually did just get approved for a clinical trial research position. So we will be expanding what we have to offer here at Southern Maryland. So that is in the works, just because it is really important for the progress of cancer treatment.
Excellent.
Okay. And I think I have two questions, and then we'll go back to the questions that are in the chat. One is, do treatments affect one's ability to have children?
It can. So it depends on your treatment. Chemotherapy absolutely can affect your ability to have children, and that's because chemotherapy can cause kind of early ovarian failure. And so for patients who are treated at a young age, so if you develop breast cancer at 35, one of the questions that we have for patients tends to be, are you interested in having more children? Because if the answer is yes, then we have questions of, you know, egg retrieval and egg preservation. There's also some medications we can give to kind of help shut down the ovaries through medications in hopes of preserving them, so that way they come back online later. But for anybody who has to go through chemotherapy, ovarian failure can definitely be a side effect. And so again, you want to just be treated with a team who is aware of what your desires are. So that way, if that is your desire, that, you know, it's brought kind of front and center, and we can try to do our best to help maintain that desire throughout your life.
And then the final one I was given was, with all the advancements, are there any plans to replace the machine that does the mammograms?
So there's always discussion of how to make a mammogram better. There's lots of things that are in the works. None of them are prime time at this point. So getting squished by the mammogram is pretty much the only thing we still reliably have. With that said, we did replace 2D mammograms with 3D mammograms, and the 3D mammograms are a much better picture. You still have to have some compression with the 3D mammograms, but it is at least a better picture. So it's definitely a huge improvement from the very, very old school kind of digital film screens. But it's still painful. I got it. I know that.
There are just a few more questions in the chat. I'm not sure if this one was already addressed. My mom and I were diagnosed at 50, so my daughters should they start screening at 40?
At 40. Yep. 40 is kind of the standard answer. If you ask around, some will say 40, some will say 45, some will say even 50, because the US task force, when they were putting up their preventative opinions, they said women should start screening at 50. US task force is all about dollar cost analysis. And so when they made the recommendation for starting screens at 50, they actually admitted that there was going to be a whole host of patients that developed breast cancer earlier than that. But the dollar cost analysis of how much it costs to screen all the women who did not develop breast cancer versus screening the women who did develop breast cancer, they decided that the average cost was better to wait till 50. Now, American Society of Breast Surgery, American College of Radiologists, basically nobody agrees with them, and everybody agrees with starting at 40. And there's even some discussion of maybe even starting younger for certain patients, but 40 is pretty standard recommendation from us.
Regarding prevention, does birth control help with preventing breast cancer?
So, no. Birth control can really help with preventing ovarian cancer, particularly if you're like a BRCA positive patient. Birth control is still exogenous hormones, and so there's actually still a slightly increased risk of taking birth control, particularly later in life, so particularly after age 30. That risk normalizes once you stop it.
This says, do you take Cigna?
I think so.
Cigna PPO insurance at Southern Maryland.
Yeah, I think so. You can always call and ask the front desk, but I'm not certain if there's any insurance we don't really take.
Can you take radiation or chemo to enhance aromatase inhibitors?
So radiation or chemo, yeah. So aromatase inhibitors are basically endocrine therapy. So that's that hormone blocking medication. And we recommend anybody who has hormone positive breast cancer to take endocrine treatment. So anybody who has an estrogen or progesterone positive cancer should take that medication. Radiation or chemotherapy doesn't potentiate the effect of that medication. The medication is kind of a standalone medication. If you're recommended radiation or chemo, it's for other reasons. So it has to do with either type of surgery, size of your tumor, or what that third tumor marker is, or what your genomic testing is. But it's not given in conjunction just to enhance it. They're given for different reasons.
If you develop lumps or enlarged lymph nodes in other places, can that be a sign of breast cancer, or is it another type of cancer?
It depends on where those are. I mean, you can get axillary, so under the lymph node, you can get enlarged lymph nodes, and that is definitely a sign of breast cancer. So if you get a really giant lymph node that's really hard and there's multiple, that can be a sign of breast cancer, but not necessarily. Lymph nodes get enlarged for lots of reasons, particularly since COVID. We've seen lots of enlarged lymph nodes just because patients got a vaccine. Just like you can get lumps that are benign in the breast, but you can also get ones that are cancerous. So it just depends on how they look and how they feel and kind of what the story around them was and when they developed.
And that was, okay, where'd it go? 1 second. Why does the COVID shot swell the lymph nodes?
Because your lymphatic system is working. So the whole point of lymph nodes is to help clear the body of infection or to help fight off infections. So a vaccine works because it's trying to make your immune system respond, and it's trying to get it to build up. And so the reason why COVID, we particularly see the lymph nodes under the armpit swell, is because the shot is in your arm. So they're the closest lymph node basin to where your shot was. But it's them just trying to work.
Okay. Does anyone have any other questions? Okay. Well, I want to thank you so much, Dr. Weiner, for this insightful presentation on the risks, prevention, screenings, and treatments associated with breast cancer. And we hope that all of you found this presentation very helpful. As always, a big thank you to our MedStar Health team for your collaboration on this important initiative, and to all of you, of course, for joining us for this presentation. Our next presentation will be Ask the Spine Surgeon, and this presentation will also be available on our social media web and on our websites, as well as on MedStar's Facebook pages. Thank you so much, Dr. Weiner, for this presentation.
Absolutely. Have a great evening, everybody.
Thank you.
you.